The Ophtacath is a lacrimal duct balloon catheter that achieves true dilation of the lacrimal duct that rapidly and effectively treats the symptoms of epiphora. Ophtacath is a less invasive alternative than incisional DCR, resulting in less trauma and eliminates the placement of tubes. Ophtacath is packaged sterile, single-use, in 2 mm or 3 mm kits. Each kit contains a single-use inflation device and balloon catheter. Bilateral kits are also available and contain an inflation device, 2 balloon catheters, and a 4-way stopcock for simultaneous bilateral inflation. The 2 mm catheter is used in patients less than 30 months of age. The 3 mm balloon is for patients 30 months and older. The term 2 mm and 3 mm refers to the outer diameter of the inflated balloon. Ophtacath's exclusive tapered tip and very low profile allows for easy insertion and removal of the balloon catheter. The catheter consists of a semi-flexible stainless steel stylet. It's covered by PBX tubing that ends with a nylon balloon. The balloon has excellent shape memory before and after inflation and is resistant to burst pressure up to approximately 15 atmospheres. Markings are placed on the catheter at 10 and 15 millimeters proximal to the working portion of the balloon. Preparation for the procedure begins by unpacking the sterile inflation device and catheter onto the sterile field, and you will require a basin of sterile water or BSS. The inflation device control button is in the unlocked position and the device is pointing downward. At this time, you insert the end of the connector tube into the sterile water or saline to fill the syringe. Hold the device upward, purge the air contained in the syringe and connector, ensure that 10 cc's remains in the syringe, then lock the plunger by rocking the control button toward the manometer. If performing a bilateral case, attach the male lure lock of the inflation device to the female end of the 4-way stopcock. Position the stopcock valve lever so that each of the 3 arrows on the blue lever are in front of the 3 connections. Then set aside. Just prior to insertion of the catheter, remove the protective sleeve on the distal end of the balloon and gently lubricate the catheter. It's important to keep that balloon sleeve on the catheter until just prior to use to ensure that nothing on the sterile field can puncture or damage the balloon. Step 1, the surgeon will pass a Bowman probe down the nasolacrimal duct into the nose and confirm the presence of the probe in the nose by metal-to-metal contact. Remove the Bowman probe. Repeat on the other side for a bilateral case. Step 2, the balloon catheter is then passed through the canaliculus and the lacrimal sac into the nasolacrimal duct until the catheter reaches the nasal floor. Again, confirm the presence of the catheter by metal-to-metal contact, again very gently because that balloon is there. Step 3, the surgeon will then pull the balloon proximally and align the punctum with the marking located at 15 millimeters proximal to the balloon. Repeat this step on the other side if bilateral case. Step 4, connect the filled inflation device to the balloon catheter. If in a bilateral case, connect to both catheters. Always point the inflation device downward while inflating. Slowly and gradually turn the rotary handle clockwise to a fill pressure of 8 atmospheres and maintain that for 90 seconds. Step 5. Deflate the balloon completely by turning the rotary handle of the inflation device counterclockwise. At this point, if a second inflation is necessary, it can be performed by reinflating the balloon to 8 atmospheres, this time for 60 seconds, then deflating the balloon again. Step 6. Pull the balloon proximally again and align the punctum with the marking located at 10 millimeters proximal to the balloon. Gradually inflate to 8 atmospheres for 60 seconds. Step 7, deflate the balloon completely. Again, at this point, if a second inflation is necessary, it can be performed by gradually reinflating the balloon to 8 atmospheres, this time for 40 seconds, then deflating the balloon again. Step 8. Now the balloon is deflated, but to ensure the balloon is as small as possible, the surgeon must draw all fluid out of the balloon. Do this by unlocking the control button of the inflation device, in other words, rocking it toward the back of the plunger, opposite the manometer, allowing the plunger to move freely. Pull back on the plunger until a vacuum is created. You'll know a vacuum is created by looking at the gauge, which will now be in the red area of the manometer. Once vacuum is reached, lock the plunger by rocking the control button toward the manometer. Step 9. Minimize the profile of the balloon while withdrawing by turning the catheter in a clockwise fashion so that the balloon folds around the stylet, similar to folding an umbrella around its shaft. Irrigate the lacrimal system with fluorescein to confirm patency of the passage. If patency of the passage is not confirmed by fluorescein irrigation, another dilation procedure can be performed, but a new catheter must be used. A few tips. Before each inflation, confirm that the needle of the manometer is set to 0 plus or minus 1. So in other words, it can't be in the red zone. It's going to be around a 0 or 1. That's okay. You don't want it any higher. If the control button cannot move from the unlock position, turn the rotary handle counterclockwise just slightly to deflate the balloon and then try to lock the device again. If the control button is difficult to lock, don't force it, as this could damage the plunger. Instead, turn the handle gently again, re-engage the control button. Lastly, if withdrawing the catheter seems uneasy, disconnect it from the inflation device by rotating the male lure lock.